I am Blessing Hoskins. My connection with the pediatric transplant is that my daughter is a heart transplant recipient. It is my pleasure to introduce Dr. Robert Boucek, who is currently chairman of research and board member for the Enduring Hearts charity. His vision is to develop robust funding mechanisms for research in the field of pediatric heart transplants. We are honored to have him speaking today about coronary artery disease in relation to heart transplant recipients.
Thank you, and it is my pleasure to go through an important topic for those of you who are familiar with heart transplantation. A couple of comments to get us started. We know that heart transplant is an incredible bridge to life for many children. And we have a story to start things off with on a positive note before we talk a little bit about one of the challenges of transplantation, and that's the involvement of the coronary arteries. So this was a note I got from a family that I had taken care of. They had subsequently moved to Tennessee and sent me this note. Just read it through you briefly, but basically she was excited because her daughter, who had had a heart transplant at 23 days of age, that I remember, was just accepted into the university in Tennessee, and she was amazed and shared this note with me at when she is 25 years out now from her transplant. So that's the goal. That's what we would view as a success. But we know that it's not yet a cure. It is a bridge to that kind of a life, but we know that there are some important questions and improvements that need to come. So today we'll talk, yes, about this very issue. We call it the longevity problem. And this is a part of the mission of Enduring Hearts, is to address the longevity problem. I'll define that for you in a minute. We'll talk about some of the causes, and we'll finish it up with a brief summary of some of the research that is being done and funded by Enduring Hearts to solve the longevity problem. If you look at this particular curve, and I'll walk you through it in a minute, this reflects the history of pediatric heart transplantation. The first successful heart transplantation that started started to identify the feasibility of transplantation in small children was in 1986. So this registry began in 1992, and we're looking at the data out to 2017. Here is the percent of those recipients who survived and the years post-transplant. So the median age reflects the age at which over 50% of children have not lived to their next birthday. And you can see there's an age dependency to that, and it varies. But this is the longevity problem. We would like all children who are transplanted really to lead a normal life and a normal lifespan. So what do we know about the causes of the longevity problem? If you look at this particular bit of evidence, you can see causes of death after transplantation. And really, it begins at 31 days of age and looks in increments of time up to greater than 10 years. The percent of deaths that each of these four complications cause is shown with the coronary artery component in red and chronic graft failure in green. And I link these two together because they're related. Rejection is something that most of you would be familiar with, and infection are also something that most of you are familiar with. We're going to focus our attention on this area over here. The causes and potentially the cures for CAV and the related problem of chronic graft failure. So what is CAV? Well, we know that the heart, just like any other organ in the body, requires a blood supply. And these arteries, also known as the coronary arteries, are the source of the blood supply of oxygen and nutrients to our heart. And there are branches to them as well. And what I'm talking about, you would have thought would be called coronary artery vasculopathy, but that wasn't the name that it was originally given. And it's actually called cardiac allograft vasculopathy. We're going to define that, and we're going to see how we possibly could be addressing that. So this is a artificial drawing depicting the coronary arteries cross-section with a wall and the blood supply inside. And as you can see, in the low risk, mild progression of this particular cardiac allograft vasculopathy, there's slight narrowing, and the risks of this are relatively trivial. And we're talking about an interval of time that scans years. And these are in the main coronary arteries. If you look at the intermediate risk, there's a gradually more progressive degree of narrowing. And then the most severe, which is the area that is most dangerous to recipients. And this is the focus of our interest in finding a solution to the longevity problem. Now, once the diagnosis of CAV is made, you can see that it significantly affects the survival after transplant. So if it's mild, moderate, or severe, there's still a significant impact with the survival after the diagnosis. So even a mild degree of narrowing is associated with a significant loss of longevity. So mild, moderate, severe, all have significant 5-year effects on survival. So we understand a little bit now of what we're going to be talking about. The coronary artery problem, the longevity problem are related. Now, what are the areas of research that are ongoing or that are needed to solve this problem? Enduring Hearts is dedicated to solving that problem by funding research to address the longevity problem. And that's our mission. What are our challenges? Well, cardiac allograft vasculopathy first needs to be detected before any intervention could be considered. We need to know what causes it and possibly be able to prevent it. But we don't know who right now is at risk to develop this. So we view this as something that is needed throughout the age groups after transplant, and for a variety of reasons really must be non-invasive. If you're going to survey every child, how often, we don't know, but it at least would need to be yearly, and we don't know how to non-invasively screen for this. The last agenda that would be served by having a good diagnostic is that if you ever come up with some treatment options to do the trials that would be necessary to show that it's effective, we need a screening tool that would be able to detect improvement in the manifestations of CAV that whatever detection device is ultimately developed would detect. So how are we diagnosing CAV at the current time? The majority of times this occurs at a time of a biopsy and typically at the annual study. And it's done with a catheter separate from the catheter that's used for the biopsy, but is used to inject a dye here through a catheter into the origins of those coronary arteries that we saw a picture of previously. That would then show up on the X-ray screen as these dark vessels here. CAV would be a narrowing of these vessels. This is traditionally how it's been diagnosed throughout the history of cardiac transplantation, both in adults and in children. Well, it's invasive, but it has another important limitation that we'll identify as well. So we mentioned that cardiac catheterization is being used to diagnose CAV, and that detects a problem in this set of blood vessels that are shown in a simulated vascular bed for the heart. And these are in the surface or epicardial coronary arteries. But we know that actually the vasculopathy begins and is most important in the coronary microcirculation, or these blood vessels here. So if we want to detect CAV at an early time period, it isn't up here that we need improvements. We need to be able to look at this set of blood vessels. And we have a few tools that can do that, and they're not invasive, but the suitability of those for pediatrics remains to be proven, and the risks of radiation exposure have to be minimized. So the insights that where we're at now is the microvasculopathy. How could we get a better handle on this? Well, there's a possibility that we could see some findings on the biopsy. This is in its early stages. A of development, and it would also likely be the early stages of CAV. You might remember I mentioned graft failure a long way back in this presentation as being a leading cause along with CAV for graft loss. But this is where the microvasculopathy is probably manifest. So here are some of the projects that we're funding. We don't need to read through all of this other than to say there are multiple lines of evidence that are being explored, some in the blood, some using magnetic resonance imaging, and others with ultrasound. Here's an example of a picture that's developed from a invention that is being funded in part at Toronto, and it's looking at ultra-fast ultrasound to show the small blood vessels in the heart. Our first truly non-invasive point of care look at the coronary microvasculature. Well, what about treatments? Well, we're funding treatment trials, and we have some listed here. Most of these are still in experimental animals because of the challenges of really detecting it in humans and the non-invasive lack of a good non-invasive tool. Share with you one study that's very promising, looking at an animal model of this particular vasculopathy. This is performed in a little mouse, and we look at the blood vessels. Dr. Cush has looked at the blood vessels here for evidence of response to a currently FDA-approved drug for another purpose. And just to walk you through this figure quickly, this is a cross-section of the blood vessel under the microscope without any evidence of CAV in this particular location, whereas after injury, there's a development of a response to that injury that's reminiscent of CAV, and that's shown here. And in this particular figure here, we see that response after there was treatment prior to the injury with the drug that is currently on the market, but not for CAV. So that shows some promise. We need a study to look at that. So that's our story. We've gone through a description of the problem. We've looked at some of the solutions. And I only wanted to end with this particular story of a couple of children. Family sent this to me. Mackenzie is the recipient of a heart transplant in the first 2 months of life. And she is now was going on 3 years at this picture. The family, after getting through that first year of transplant, decided they were ready to continue their family. Things had settled to the point where they could function pretty normally, and they decided to have Mackenzie's brother. And that's their story, and it's a story of that's always meant a lot to me. So at that point, we'll stop and entertain any questions that you might have, and I'll try to address those.
Hey, Dr. Boucek, we've got one question that was addressed. What can be done to avoid Allograft Vasculopathy and pediatric heart transplant recipients? So how can they avoid CAV?
Well, we actually don't know the answer to that. There are some multiple causes identified, and they include rejection. They include some aspects of the donor acquisition. It could easily be any injury. We just don't know the cause. So it's hard to know how to prevent something that for which you right now don't know the cause. We're investigating that and looking for ways to model this in experimental settings, similar to what you've seen with the mouse. But we need to be able to do that with human cells in a virtual heart type vessel setting.
Okay, another question is, can a new heart transplant address the issue of CAV?
Well, yes, that's an important question. It obviously would reduce the risk of CAV in mediated sickness, debility, or even death with a new heart. So it's life-saving, just like the original transplant. Unfortunately, having prior CAV may predispose you to get CAV again in your newly transplanted heart. We're not exactly sure what that risk, how high that risk would be, but that's been a concern. All the more reason that we really need to better diagnose, come up with better treatments, and start them at an earlier time than we've been able to do to date. So more diagnostics need to be there. There are some blood tests that we're looking at that could have promise, but we need better diagnostics. And then I think we can really tackle the problem of CAV.
Okay, and then one last question. It looks like sirolimus is better for avoiding CAV. How do the other immune suppressants measure up?
Well, only indirectly is the thinking. By preventing rejection, and rejection is a risk factor for the development of CAV, they play a role. But only sirolimus or everolimus have shown promise in reducing the frequency of CAV in pediatric age group.
Okay, I would like to take the time to thank you, Dr. Boucek, and the audience for their time. And I encourage you guys to visit the booths and the networking area before the next session. The next sessions here are going to be Innovations in Kidney Transplant by Dr. Goebel and Kidney Health for All Transplant Recipients by Dr. Amaral. If there's no other questions, we will be closing the session.